Hello, and welcome to lecture for today. My name is Dr. Andrew Craig, and the topic for today's lecture will be pain and pain scales. This lecture piggybacks nicely off of last week's lecture of the nervous system, and I decided to split these two lectures up. One, because it would just be too long, too much information to throw at you all at once, and two, because it's important for you to understand the different um, nervous system pathways. And then in this lecture, we're going to hone down and just focus on sort of the pain pathways. Okay, so we'll talk about different types of nociceptive pain, the pain process, um, referral pain, all those sorts of things. Uh, we'll kind of finish off with talking about the gate control theory of pain, which is not unique to this course. Maybe if you've taken any other perception courses, or it's a big topic in psychology classes as well, you may have learned about it. But we'll go through that. I've also included a number of videos that will be very helpful for you to understand these processes. And I think a quick 5 to 10 minute video can really help to ingrain this information in your brain when you go back to study for this for midterms and exams to learn the concepts that I'm trying to kind of deliver home to you. So we'll talk about the different types of pain, as I mentioned, and then we will finish off our discussion today with some pain scales and some outcome measures, the visual analog scale being one, and an important outcome measure called the SF-36. And so the pain is truly a subjective sensation. Okay. When I feel pain, if I was to rate it on a scale from 0 to 10, it might be different from your experience from pain. And so that's what I mean by subjective. It really depends on the observer and the person who's actually experiencing the pain. And so when we ask people, what's your pain level? It's very challenging to um, it's very challenging to compare between individuals the pain experience. So we rely on these outcome measures like the SF-36 in order to be able to have some sort of objective measurement to say this is their experience with pain compared to others. And again, it's not perfect, but it's the best we've got. So that's what we use to kind of objectify the pain experience in individuals.
Today, we're going to discuss all things pain. We're going to look at some classification systems. We're going to look at neurological processing. We're going to talk about some referred pain. And then we will talk about chronic and acute pain a little bit more in depth and the gate control theory of pain, which you've likely experienced or learned about in previous physiology classes. Once we're done talking about pain, then we're going to talk about a couple of different outcome measures or different scales that you can use, specifically the visual analog scale or the VAS, and the SF-36, or the short form 36 and the short form 16. Pain can be very complex, and it can be classified by a number of different strategies. You can talk about pain in terms of the region of the body that you're experiencing it. So is it chest pain? Is it low back pain? Is it neck pain? You can also talk about pain in terms of what systems it's affecting in the body. We can talk about joint pain like arthritis. We can talk about visceral pain. We can talk about neurological pain. We can talk about musculoskeletal pain. So looking at what system of the body we're dealing with. We can also talk about the duration of pain. So as we discussed last week, chronic, subacute, acute. Those are good indicators. We can also talk about the frequency of pain, whether it's intermittent, whether it's persistent, if it's post-exertional or post-motor vehicle accident, or if it's an isolated incident. That can be helpful to know sort of the cause of it. We can also discuss the intensity of the pain. So is it mild, moderate, severe? How is that changing over time? We will look at a couple of outcome measures that can help you identify that today. And then you can look at the etiology or the cause of the pain. Is it infectious? Is it a cancerous lesion? Is it arthritis? That can give you a lot of information on appropriate treatment strategies, whether there's any exercise that is contraindicated or more indicated, that sort of thing. So it's important to know what classification we're looking at. A lot of times we will classify it in each of these systems. And that can be just a much more vivid description of what we're dealing with on a person by person level. There's also a number of different types of pain that your body can perceive. So you can have neuropathic pain, you can have mechanical pain, you can have nociceptive pain. There's chemical, there's temperature, all different types of pain, and we discussed a number of those mechanoreceptors last week. Nociceptive pain, just a quick little definition here for you. This is pain that's caused by stimulation of peripheral nerves. This can be in the form of thermal, mechanical, chemical irritation. These are sort of the most common painful stimuli that we experience from the periphery that enter into the central nervous system. Okay, so experiencing pain is a process. There are a lot of neurological systems involved with processing pain. But in essence, what happens is we experience the pain in the periphery. Okay, so we have pain receptors in, let's say, we'll say with our hand. If you touch a hot surface, you've got pain receptors in the hand, and that encounters a hot surface or the stimulus. Okay, that's going to stimulate thermal receptors, and those thermal receptors are going to stimulate that first order neuron or the first order nerve that's going to take that signal to the central nervous system or into the spinal cord. Okay. When you touch that hot surface, there is going to be a action potential that is created. Okay, that action potential is going to travel along that sensory nerve in through that dorsal root ganglion into the central nervous system. Once it's in the central nervous system, or once it's in the spinal cord, it's going to synapse onto that second order neuron. Okay, and that second order neuron is what's going to travel up and into the brainstem, and then into the brain, into the thalamus, which is where it synapses onto that third order neuron that's going to travel to the somatosensory cortex. So we're going to discuss that process in detail over the next couple of slides. But if I had to summarize the pain process in sort of 3 steps, or 3 to 5 steps, the painful stimulus is encountered in the periphery. It travels to the central nervous system through the first order neuron. The second order neuron takes it from the spinal cord to the thalamus. So it ascends through the ascending tract to the thalamus, where it synapses onto a third order neuron, or the end effector neuron, which takes it to the somatosensory cortex. This image is vitally important for you to understand. Okay, this is how we sense anything in essence. Okay, you've got 2 systems. You got the spinal thalamic tract, and you've got the dorsal column system. Okay, these are 2 separate pain pathways that transmit different information. The spinal thalamic tract, that transmits pain and temperature sensation. Okay, the dorsal column system, that transmits your fine touch and your proprioception. Can anyone think why having 2 different pathways can be important clinically, and how we can use that to our advantage? Well, clinically, if someone has difficulty sensing temperature regulation, okay, let's say they touch a hot surface or a cold surface and they can't tell the temperature, likely we're having trouble in the spinal thalamic tract. If that's the case, their fine touch and proprioception might be totally intact, because that takes a totally different path to the brain. Okay, so think of it kind of like 2 different highways. You've got the 401 and you've got the 407. If you need to get to downtown Toronto from Ontario Tech North Campus, are you going to take the 407 or are you going to take the 401? The 2 different pathways to the same sort of end goal, or the somatosensory cortex. So let's start with the spinal thalamic tract. Okay, and this is where we're going to sense pain and temperature control. You get a painful stimulus, or you touch a sharp object in your hand. that first order neuron is going to sense that pain. It's going to send it through the dorsal root ganglion, okay? And then it's going to synapse onto that second order neuron in the spinal cord. Once it synapses on that second order neuron, what happens with the spinal thalamic tract specifically is that second order neuron crosses the spinal cord at the level of the spinal cord. It ascends through the spinal thalamic tract. It goes through the midbrain. There's no synapse at the midbrain. And it enters into the thalamus where it synapses with that third order neuron. That third order neuron transmits that signal to the somatosensory cortex. And now, since it was our hand that we touched that painful stimulus on, it's going to send it to an area of the somatosensory homunculus that corresponds to the hand. Okay. The somatosensory homunculus we discussed last week, and essentially a map of the somatosensory cortex of where certain areas of your body are represented within the brain. So that's the spinal thalamic tract. As you can see, it's the second order neuron that crosses to the other side of the body. And you'll notice that information coming in, this is from the right side, this is from the right hand coming in through the right side of the spinal cord, and it's always sensed on the left side of the brain. Okay, so sensory information is always processed on the opposite side of the brain to the body. The dorsal column system, so let's say proprioceptive information, it enters through, again, the dorsal root ganglion. It synapses on the dorsal horn of the spinal cord, and it ascends. So as you can see, it does not synapse with a second order neuron here. It ascends to the medulla, and this is through the dorsal column system. In the medulla, it will synapse with that second order neuron. At this point, that second order neuron will cross the spinal cord at the level of the medulla, and it will ascend to the thalamus and then send the information to the somatosensory cortex through that third order neuron. Important things to distinguish between these two tract systems. The spinal thalamic tract, the first order neuron synapses at the level of the spinal cord. Okay. In the dorsal column system, it actually ascends the spinal cord to the medulla, and the synapse happens at the level of the medulla, which is in the brainstem. Another thing to recognize is the second order neuron, or the green neuron in both of these images, is the neuron that desiccates or that transfers from one side of the body to the other. Okay. Now, in the spinal thalamic tract, this happens at the level of the spinal cord. In the dorsal column system, this happens at the level of the medulla. I know that that's a lot of information, and I think you can understand why I didn't include it in last week's presentation. But I want you just to go through and understand the differences between these two systems, okay? And in a few slides, I'm going to give you a video that has an absolutely beautiful description of this with images that are drawn out as well. So please, please, please make sure you go through that. Now, I think you can understand that pain can be very confusing. And from an anecdotal perspective, you've probably injured yourself in the past, and you know that it can be a minor injury and feel like one of the worst things you've ever experienced. And it can be a major injury and not be so painful, right? So it is this sort of multifactorial experience. It can be short-lived, or it can be a long-term injury. It can be something that's bothering you just at a local specific area, or it can be systemic and affect the whole body. Or pain can even be referred from one area to another. So let's say you have a headache, that can be happening in the cervical spine and just referring to the head. So it can be very, very confusing to identify the areas, identify the causative agent. And so we need to take what's called a biopsychosocial approach to pain, because there are multiple factors that we need to consider. This slide gives you a bit more depth in the understanding of acute, subacute, and chronic pain. So, as we mentioned last week, acute pain is anything that has occurred within the last 3 months. It's typically from some sort of specific injury, and it typically disappears within that 3 month period. Once tissue damage repairs, you'll get significant improvement and then marked improvement over time. Acute injuries would be, let's say, something like you roll your ankle, or you've had what's called a fouche injury, which is a fall on the outstretched hand. Yeah, fall on the outstretched hand, where you could injure your hand or your forearm. It's short-term damage, and it's going to recover within a short amount of time. Subacute is when things have lingered a little bit longer than 6 weeks, and they're still working within that acute phase. Okay, so it's a subset of acute pain. Some things will recover within 6 weeks. Some things linger a little bit longer. I like to use back pain as an example here. Most back pain episodes, if it's a mechanical issue, and if you've sort of quote unquote thrown your back out, usually it will be taken care of in less than a subacute phase, so less than 6 weeks. Chronic pain, on the other hand, is more than 3 months. Typically, chronic pain starts with an acute episode of pain, but it doesn't resolve within that 3 month time period. There's often more psychosocial and psychological stressors that are contributing to pain in this chronic phase. And this can complicate our understanding of the injury. This can complicate our decision making in terms of treatment, and it can actually impact diagnostic criteria. Treatments that are effective in the acute phase are often not effective in the chronic phase. This is because you've got different types of inflammation that are happening. You've got different pain perceptions. You've got different understandings and expectations from the client or the patient. And so there is this complex interaction between psychological, physiological, and behavioral components within the management that can complicate chronic pain conditions. Okay. There are literally medical specialties that just deal with chronic pain. It is a very, very complex issue within healthcare. Referred pain. Referred pain is very, very interesting. There's lots of research in this area, but I still think there's lots of space to expand our understanding. If you're interested in looking at neurological pain and pain perception and pain understanding in individuals, this could be an interesting area for you. So referred pain is when a painful stimulus is occurring in one area, but it's perceived in another area. So a great example of this would be cervicogenic headaches, where headaches are actually occurring due to pain in the neck, and we're going to discuss that in just a minute. You can also have visceral referral, which is when a great example is if you have issues in the gallbladder, you can have gallstones or some type of other issue, infection, whatnot. You can get referral to the shoulder. And this is a really interesting one clinically, because what happens is when the gallbladder is active, the person will get shoulder pain. So let's say they eat a meal that's very high in fat or very high in cholesterol content. The gallbladder is going to be highly active. And so when the gallbladder is highly active, that's when you're going to get pain. So a very funny clinical pearl is if somebody has shoulder pain and they have no reason for it, there's no mechanism of injury, there's no overt musculoskeletal pain or complication, ask them, do you notice that that pain comes on after you eat, say, a high fat content meal? They might say yes. That can be an indicator that the gallbladder is problematic. So referred pain, it can be when organ pain mimics joint or musculoskeletal pain. That's, for example, with the gallbladder, and we kind of call that viscerosomatic referral. It can also be when muscular pain mimics other muscular pain, and that's called musculoskeletal referral. A couple of prime examples are cervicogenic headaches. And so referred pain can come from the suboccipital muscles, it can come from the sternocleidomastoid, or from the upper trapezius, or upper fibers of the traps. So the suboccipitals are muscles that anchor your skull to your first two vertebrae. They are innervated by the same nerve roots, C1, C2, that innervate the scalp or the dermatome for the scalp. Okay. So when the suboccipitals are tight, or if you're having a painful stimulus to the suboccipitals, it can be sensed as the dermatomal distribution shown here on the bottom right. So if people have really tight suboccipitals, if you palpate them, and you can cause a painful stimulus that comes up and wraps around the back of the head. Same thing is true for the upper fibers of the traps. In the upper right, you can see there are some trigger points within the trapezius, or sorry, the upper traps that can refer up and around the head and even cause headaches behind the eye. So clinically, I want you to think, how does this occur? Like, how does referred pain actually happen? And there's a couple of reasons for it. This is a description of that organ or visceral referral. Okay, so the reason it happens is the nociceptive afferents from viscera enter the spinal cord at the same spinal segmental level as the nociceptive afferents from the skin, the muscle, and the joints. Okay, so for example, let's go for the gallbladder, like I said. So the gallbladder has the nerves that innervate the gallbladder enter the spinal cord at the same level as the dermatomal distribution over the right shoulder. So if the gallbladder is overactive, you can get this weird referral pattern over the right shoulder after the individual, say, eats a fatty meal, as I said. So the reason for this type of referral pattern is you've got convergence of neurological impulses onto a common nerve that can be misrepresented as coming from a different area. Let's talk about the suboccipitals again. So the suboccipitals are innervated by the suboccipital nerve, which involves the upper cervical nerve roots. This is true also for the skin over the back of the head. So the convergence of these signals onto the same nerve roots can be misinterpreted by the brain and result in that referral pattern experience. Secondly, the greater and the lesser occipital nerves travel through the suboccipitals. So if we go back a slide, underneath the suboccipitals is where that greater occipital nerve and lesser occipital nerve emerge. And so if those suboccipitals are very tight, they can compress those nerves and cause referral pain into the back of the skull. These types of sort of misrepresentations of the pain signal, they follow typical patterns, and clinically we can predict those patterns. So they can help us to, be more accurate in our diagnosis, understand what we want to treat, and we can look at these referral patterns for clinical insight. Now, the next thing we're going to talk about is the gate control theory of pain. And I'm almost certain you've talked about this again in some sort of neurophys class, but we're going to review it. And I want you to watch this video. This video is excellent for a very simple review of the pain pathways. So the track systems, but it's also a good descriptor of what we're looking at in terms of the gate control theory of pain. So the gate control theory of pain is how painful sensations can be blunted or reduced by activating non-painful sensations. And this helps to override that painful stimulus. So let's take the example of, if we look on the left here, let's take the example of you, everybody's done this, or at least I have many times, I did this weekend, but hitting your thumb with a hammer by accident. Okay, it's obviously going to cause a painful stimulus. It's going to activate pain receptors, and it's going to send a nerve signal down that primary neuron into the dorsal root ganglion and then into the dorsal horn of the spinal cord. Okay, so that's the primary neuron, or the first order neuron. That pain signal is going to transmit from that first order neuron to the second order neuron. It's going to desiccate or cross the spinal cord, and then it's going to ascend through that spinal thalamic tract. Okay. As it ascends through that spinal thalamic tract, it's going to synapse onto the third order neuron at the level of the thalamus. Okay. So it's going to synapse here. It's going to send that painful stimulus up to the somatosensory cortex through that third order neuron. Okay. What happens is that if we backtrack a moment here, that first order neuron, when it enters into um, the dorsal horn of the spinal cord, it releases substance P, which is a neurotransmitter that initiates that second order neuron to fire, and that's the neurotransmitter that communicates that signal. Okay. Now, if you slam your thumb with a hammer and then you immediately start to rub it, which seems to be almost a reflex for us, that deep touch can actually inhibit that pain stimulus. Okay. And this is the gate control theory of pain. So when you apply deep pressure or deep touch to your thumb, you're going to activate the Pacinian corpuscles. Okay. When you activate the Pacinian corpuscle, you're going to activate that first order neuron, which is going to travel to the spinal cord, enter through that dorsal root again. And if you remember from the previous slide, deep touch is transmitted through dorsal the dorsal column, okay, as opposed to the spinal thalamic tract. So it will ascend, it will synapse on a second order neuron, which is going to ascend through the dorsal column to the brainstem. At the brainstem, then you're going to have that synapse to the second order neuron, which is going to go to the thalamus. And this is where it can sort of mediate or inhibit the signal. Okay. So you're rubbing your thumb, that signal initiates the Pacinian corpuscle, which is going to travel to the thalamus, and you're going to get an inhibition signal to that third order neuron, which takes the pain signal to the brain. So this is the first area that you're going to have inhibition of that signal. So it's going to reduce the firing rate and reduce the pain experience. At the same time, if we go back to the level of the spinal cord, okay, and we zoom in on it, this is the area called the substantia gelatinosa. And so what you have is the green nerve here. This is the original primary neuron from the painful stimulus, okay? And this is where it's going to synapse onto the secondary neuron, and that's going to send the painful stimulus up to the thalamus. The purple neuron here, this is that the inhibitory or the gate control neuron, and it attaches to an interneuron. This interneuron also attaches to the second order neuron for the painful stimulus, and it can reduce the transmission here. It's sort of releases enkephalons. Enkephalons are the inhibitory interneuron neurotransmitter. And so those enkephalons, they will reduce the amount of substance P that's that's produced by the presynaptic terminal. It's also going to attach to the postsynaptic terminal and reduce the firing rate of that second order neuron that's transmitting the painful stimulus. Okay. Now, again, please watch this video, watch it a couple of times because it will explain that in detail. But what I want you to take away from this is that the gate control theory is this idea that by using deep touch, you can inhibit that painful stimulus. Okay. So you can rub the thumb to create this inhibitory signal, and that inhibitory signal happens at the level of the substantia gelatinosa. And it also happens at the level of the thalamus to reduce the painful stimulus that the somatosensory cortex perceives. So the substantia gelatinosa, this is the gate, essentially, for that painful stimulus, and it can reduce the amount of stimulus that that second order neuron experiences. Next, we're going to move on to discuss the visual analog scale and the short form health survey, or the SF-36. We're going to look at these as outcome measures primarily for pain management, but they do have applications in different areas of clinical practice. So the objective for you here is to be able to identify and understand the use of the visual analog scale and the SF-36 for pain management, to be able to score them, to understand, excuse me, to understand how they correlate to other measures as well. The visual analog scale I use in everyday practice. It's a common psychometric response scale with widespread applications. You can use it for pain, you can use it for exertion. It's very simple and it's adaptable to a wide range of populations and a wide range of settings. So it is a measure of pain intensity and pain experience, and it attempts to objectify it by asking the individual to rate their pain. So it is highly subjective, okay? And you need to make sure that you sort of gauge the individual's response, okay? Because all individuals have different pain tolerances, and all individuals will have different intentions on how they are answering you. So, for example, if you say to somebody, if you're having a jovial, joking conversation with someone, and you say, "Okay, back to the topic, like, how bad does your ankle hurt?" And they go, "Oh, it's a 10 out of 10." And that doesn't really match up with what you're observing with how they're walking or with how they're talking about their pain. Sometimes there can be an exaggerated response there. On the other side of things, if somebody is very resilient to pain and has a very high pain tolerance, they might underplay the amount of pain that they're in, and they might call it a 2 out of 10 because it's not affecting them psychologically quite as much. So you need to understand the intentions, you need to understand each individual's pain tolerance. This is the vertical visual analog scale. There's also a horizontal, which is more traditional and I see more often. But the vertical one fit nicely on this slide, so the horizontal will be on the next one. And the visual analog scale, it's this continuous scale as opposed to a discrete scale. Continuous meaning they can put their line anywhere to indicate the amount of pain that they're having. So it's a scale from no pain to the worst pain imaginable, and the individual can sort of make a tick anywhere along this line to indicate the amount of pain that they have. This is most appropriate for assessing within individual change, or from if myself, if let's say I scored this last week and it was here, and this week it's way down here. That's a good measure. So that's a within individual change. It's good because it takes less than like 10 seconds to complete. There's really no training required to administer this or to complete it. And it has high cultural adaptations, high cross-cultural adaptation. So anybody can really understand this, okay? The biggest problem is right here. It is highly subjective, okay? What is each person's 10 out of 10? And this is really important to ask them and to explain, what is your worst pain imaginable? Because everybody's going to be different, right? Everybody's experienced their own perceptions with pain, and everybody's going to differ in their worst pain imaginable. So there is some research that suggests that the visual analog scale is a superior metric to its discrete counterpart. And discrete means there are specific numbers that you have to select. So from 0 to 10, how bad is your pain? That's a discrete scale. Whereas this one is just a line. Okay, so there is some research to suggest that people aren't as impacted by a continuous scale as they are with the discrete one. So the way that you score this is the individual will mark on the line, and let's say this is a 10 centimeter line, then I can measure from 0 to the mark. And the nice thing here is you aren't just confined to that 0 to 10 scale. If they mark it at, say, 5.5 centimeters, then it's a 55 millimeters, or if 78 millimeters, 23 millimeters, whereas a discrete scale will only be 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And the numeric rating scale, this is the name we give to that discrete scale. So there is a clear correlation between how people score on the visual analog scale and the numeric rating scale. Numeric rating scale and the visual analog scale are often given together. You give a line with the numbers, and so you can go from 0 pain to 10, which is sort of worst pain imaginable. And there's different versions that you can use, which I like. So for children, often you'll see these happy faces to sad faces, and they can sort of represent their pain visually. You can also use a discrete scale where anywhere from strongly disagree to strongly agree. So how does the visual analog scale compare to the numeric rating scale? They're rather similar, but if you are looking to compare between, moderate pain on the visual analog scale will correlate to greater than 30 millimeters. Severe pain will correlate to greater than 54 millimeters, and the literature suggests that males and females score very equivalent, so there's no need to distinguish between males and females on those measures. In general, a 0 correlates to no pain. A 1 to 3 corresponds to mild pain, 4 to 6 is moderate, 7 to 9 is severe, and 10 out of 10 pain, or if they're totally on the one side of that visual analog scale, that is the worst pain imaginable. Typically, this is reserved for people who should be at the hospital, are bedridden, or it can be an exaggerated response, as I described before. If it is an exaggerated response, it can be important to document that. Oftentimes in my clinical notes, I will put patient reported 10 out of 10, suspected exaggerated response based on observation and other historical findings. So how do we determine if there's a significant amount of change in their pain level? Like, do we care if is 1 centimeter of change important? Does it need to be 5 centimeters? Plenty of research has asked this question, and we've sort of returned some interesting data on what we should be looking for. And the term that we use for this is the minimum clinically significant difference. Okay. This is the term given to the amount of change we would attribute to an important or significant finding. Generally, it's dependent on the area that you're looking at. So low back pain is going to differ from a rotator cuff condition, and RA or rheumatoid arthritis is going to change from emergency room visits. So there's research in all different areas. People will look at a specific condition. But for rehab purposes, in general, what we want to see is a change in 20 millimeters or more to indicate significant improvement or significant aggravation of symptoms. Okay, so 20 millimeters or 2 centimeters is what we look at in general for rehab. The strengths of the visual analog scale are that it's very simple to implement. It's adaptable to a wide range of clinical scenarios and populations, and it's been used for many, many years. So we've got tons and tons of normative data. It's well understood. It can be applied across really any sort of population. And it's a great scale visually, and it's a great scale from an objective measure as well. Now, I'm always weary of research that just bases information on the visual analog scale, because it is highly subjective. So one of the major limitations is that it's very subjective. People need sort of a baseline level of cognition to complete it. So if there is any sort of cognitive or motor impairments, they might be prone to not being able to complete the visual analog scale. And unfortunately, it can't be administered by telephone, which sort of does limit its usefulness in research. But that's where you would use the NRS, or the numeric rating scale, numeric pain rating scale instead. The last outcome measure that I want to discuss is the short form health survey, or the SF36. This is a much more in-depth health survey. I suggest that I'll give you a link to this survey, and I suggest that you go through and complete it on your own just to see how involved it is. But the SF36 is a measure of health-related quality of life. Okay. It's a multi-purpose generic health survey form that has wide utility in research and in clinical settings. It's a patient-reported survey of the patient's overall health. It's been validated at measuring 8 health outcomes. So there are 8 health outcomes across 2 categories, and it yields an overall quality of life score that can be used to indicate overall health, and it can also be broken down into its components to assess certain areas of functioning. There is also a SF16, which is another health outcome form. It's just a short formed version of this. Okay. And again, I'll give you a copy of that survey on Canvas. The SF36 can be divided into physical health aspects and mental health aspects. So that's the 2 different categories that we're looking at: physical health and mental health. The physical health component can be broken down further into 4 areas of functioning, and this includes physical functioning, physical role, bodily pain, and the social role. When we average the score in these 4 dimensions, we get what's called the physical component score. And this is how we sort of assess, this is how we use the SF36 to assess their basically their physical abilities, their physical functioning, and whatnot. So this, combined with that mental health score, can give us an overall understanding of what's happening with the individual. So the mental health score, this can be broken down into mental health, emotional role, vitality, and general health perceptions. And these are the 4 subcategories of the mental health component score. So we look at the average of those 4 and we get that mental health component score. The overall health score, this is going to be our average of the physical component score and the mental component score. The interpretation of this outcome measure goes from 0 to 100, and a score of 0 is equivalent to maximum disability, whereas a score of 100 is equivalent to no disability. So the higher the value, the better the individual's health and functioning is. This this outcome measure is an absolute sort of a nightmare to score. And so typically you will use software to do this, but I've given you these scoring tables on this slide to see how you actually score this. So you look at the item number, so 1, 2, 20, 22, 34. All of these items within the SF36 are going to be scored based on this criteria. Numbers 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, they will be scored in this regard, and so on and so forth. So what you have to do is you have to go through the SF36, score each of these based on the scoring criteria. Then you have to place them into their different bins. So if we're looking at physical functioning, there's 10 items. And so we have to go, okay, so number 3, how is that scored? Okay, so 1 was equal to a 0 and 2 was equal to a 50. So you have to record all of those in a chart as well. I'm not going to make you do this because there is tons of software that you can use. Feel free to check out this hyperlink here, orthotoolkit.com, SF36. And this will score it for you it makes light work of something that's just very tedious. So, from a research perspective, the SF-36 is excellent for assessing health related quality of life. It's an objective measure. It is well used. If you've done any sort of reading in public health literature, you've definitely come across the SF-36. Personally, from a clinical perspective, I use the SF-36 for specific questions. Okay. So if I'm overtly concerned about somebody's social functioning or their physical functioning, I'm going to go and use these questions specifically and look how they're functioning in those areas. I do find that the overall sort of health score is a great way to start a discussion with patients and clients as to why they should be engaging in physical activity. And then you can use the specific questions to show, look, we can help you in these areas of functioning, which is going to bring up your overall health from an objective perspective with the SF-36, but also from a subjective perspective to the individual, which is really, at the end of the day, what we're looking to improve. As I mentioned, the SF-36 has a ton of literature supporting its use. It's been shown to have very good internal consistency, which means that the questions are reliable within the SF-36 and they're not dramatically different in terms of their applicability. It has very it has adequate test to retest reliability, which refers to the fact that if the same person took it twice, they're going to score the same or at least very similarly when they take it both times. It's got good correlations with other similar health outcome measures. It's got good construct validity, meaning that the test has been validated to measure what it's supposed to. So, does it really measure what it claims to? Yes, we can say that it does. It also has adequate criterion validity, which means like how does it measure up to the gold standard or the best known tests that look at this type of characteristic. And so, believe it or not, the SF-36 isn't the longest health outcome measure. So it does match up quite well to gold standard measures. And then it's also adequate to change. So it's got an adequate sensitivity to change, meaning if there's change in the individual, the SF-36 will pick it up. And that's all that I had for you today for our lecture. We reviewed a number of complex topics, and I really encourage you to watch the videos that I've posted to Canvas and the video that I've posted to this lecture, because it's very important for you to understand those pain pathways and how pain can be inhibited. Okay. Thank you for listening, and I hope that you have a fantastic day and fantastic week, and we will reconvene during our next lecture. Take care, everybody.